Well, welcome everybody to this evening's lecture. Vet Education is proud to present a free webinar called Stay Away from the Gas, all about MAC reduction in the emergency and critical patient. This lecture has been brought to you by an upcoming course that we have starting on April 18. It's called Anaesthesia and Analgesia in the Emergency and Critical Patient, where we're going to dive into a whole bunch of stuff about anesthesia and analgesia in the emergency and critical patient, ranging from neurological patients to respiratory patients, patients with the acute abdomen, patients with urinary tract disease, and a whole bunch of other things, all about analgesia and anesthesia. More about that a little bit later on tonight, but let's get underway with tonight's session. Why should we consider MAC reduction, and what do we mean by MAC reduction? Well, by MAC reduction, what we mean is that we're going to turn the dial on our vaporizer down. We're going to try to use some techniques to decrease the MAC of whatever inhalant anesthetic gas you use. Most of us are using isoflurane, but some are using sevoflurane and so on. And regardless, we're going to try to reduce the amount of inhaled anesthetic gas that we give our patient. And the reasons for this are going to become evident as we progress through the lecture. We're going to talk a little bit about the properties of inhalant anesthetics. We're also going to consider, while we're considering MAC reduction, the physiology of the critical patient, specifically regarding their cardiac output and also their blood pressure maintenance as well, because obviously if we take a normal patient and induce anesthesia, we do affect cardiac contractility and we affect vascular tone to a greater or lesser degree depending on the anesthetic drugs that we choose. And in the critically unwell patients, sometimes the effects on cardiac output and blood pressure can be quite profound. And this is one of the reasons why we may want to, in some patients, consider reducing the quantity of inhaled anesthetic gas. And then to reach the middle of the lecture, we're going to be talking about some of the clinical studies that compare inhaled anesthetic drugs, most notably isoflurane, because it's the one that's been most widely studied in comparison to injectable anesthetic agents like propofol and ketamine and alfaxolone. And then to finish off, we're going to devise a couple of anesthetic protocols, or I want to take you through what I do when I'm considering anesthetizing a patient with head trauma, for example, or a patient with respiratory disease. And then you and I together are going to develop a protocol or a series of drugs that we might be able to administer a patient with gastric dilatation volvulus syndrome, just as a bit of an exercise to finish things off. So let's have a look at some properties of inhalant anesthetics. Okay, most people are not using halothane now, but there are a few clinics still using it in some parts of the world. But if we look at the general properties of inhaled anesthetics, halothane, enflurane, isoflurane, desflurane, and sevoflurane, we can see that, isoflurane, let's pick on this one here because it's the most commonly used, causes a decrease in cardiac output, a decrease in mean arterial blood pressure, and an increase in heart rate. So despite the increase in heart rate, we still end up with a decrease in cardiac output. Okay, desflurane, we don't see too much of a change in cardiac output, but mean arterial blood pressure still falls and heart rate tends to increase as a result of that decreasing mean arterial blood pressure. And we see a similar sort of thing with sevoflurane, which decreases mean arterial blood pressure. So if you're using isoflurane, I want you to think of two important things. One is that it is a potent depressor of myocardial contractility. And that's one of the reasons why when the heart rate increases in response to decreasing arterial blood pressure, we don't get an increase in cardiac output. In fact, we get a decrease in cardiac output. So isoflurane decreases cardiac output and decreases arterial blood pressure. And these effects are dose dependent. So the lower the dose of isoflurane we have on our vaporizer, the less these effects are seen in our patients. So we see less decreases in cardiac output. We appreciate a smaller decrease in arterial blood pressure as well, and perhaps a smaller increase in heart rate as a result of that. There are several advantages to inhalant anesthetics, and I will state from the outset that I'm not a specialist anesthesiologist, but I have lots of experience in anesthetizing emergency and critically unwell patients for a whole range of reasons, be they to manage an acute airway obstruction through to anesthetizing a very, very unwell patient with sepsis in order to place a feeding tube in them to help them recover from a disease like pancreatitis, for example. And in most of these anesthetics, I will still use inhalant drugs because they do have some advantages. Most of these drugs have got minimal hepatic metabolism, except halothane, which is about 25% metabolized in the liver. But if you have a patient with liver disease, using a drug like isoflurane has some advantages. Once patients are anesthetized, and at a stable plane of anesthesia with inhalant anesthetics, they have really good analgesia during the intraoperative period. They feel nearly no pain if we have them at a surgical plane of anesthesia. And they get excellent amnesia as well. So when the patient wakes up, they don't remember what it was that we did to them. The disadvantages of inhalant anesthetics are that they are markedly hypotensive, and isoflurane, as we've already seen on the previous slide, markedly reduces cardiac contractility. And they are also hypotensive, which I've repeated then because it's very important. So when we superimpose the effects of these anesthetic drugs, I'm just going to go back a slide, particularly this hypotensive and reduced cardiac contractility, when we superimpose these disadvantages onto a critically unwell patient, we can end up with an anesthetic that becomes a lot more difficult when it comes to maintaining cardiac output and blood pressure. And there's a couple of reasons for this. The main reason is that in critically unwell or in emergency patients that have significant trauma or physiological disruption, we end up with secretion of a large number of cytokines from activated white blood cells. So take a dog with parvovirus enteritis, for example, or a patient with pancreatitis, for example. They have significant white blood cell activation or significant tissue trauma. And this will lead to the development of an inflammatory response in response to tissue trauma. And this would be the same in a case that a patient that has, for example, been a victim of a dog attack or perhaps been hit by a car, or a patient that has gastric dilatation volvular syndrome. Okay, so we can get release of large numbers or activation of large numbers of white blood cells. Now, white blood cells secrete numerous cytokines, inflammatory mediators that exert various effects on effector cells. Now, two of these in particular, nitric oxide and platelet activating factor, are both potent negative inotropic agents. Okay, so they will decrease cardiac contractility. There are also vasoactive agents as well that decrease vascular tone in tissue. So the reason we're talking about this is when we're talking about emergency and critically unwell patients, we're not just administering an inhalant anesthetic agent that a healthy patient might tolerate, perhaps at an isoflurane concentration of 1.8 or 2%, for example. We might have a patient who becomes more sensitive to the hypotensive and negative inotropic effects of inhalant anesthetic agents, simply because they have these inflammatory mediators in their systemic circulation. So that's really what I wanted to cover just in very, very briefly with regards to the pharmacology of the inhalant anesthetics and also the reasons why in some cases we may want to steer a little bit away or minimize the use of inhalant anesthetics. And to paraphrase the title for this session, to stay away from the gas. There are numerous clinical studies that compare inhalant anesthetics with injectable anesthetics, and I want to have a look at these because they provide us with some of the evidence behind what we might need to consider when we're choosing an anesthetic protocol for our patients. The first is isoflurane versus propofol continuous infusion. Now, this comes from a couple of studies here, but in essence, the summary of the findings from these studies were that patients who had a propofol continuous infusion as total intravenous anesthesia versus those patients that were maintained with isoflurane alone, the propofol group had a higher mean arterial pressure. They had a decreased requirement for vasopressors, and it was quite a significant decrease in requirement for vasopressors, 14 times less requirement for vasopressors than patients that were maintained on anesthesia with propofol. There was a lower incidence of intraoperative hypotension. The recovery scores were better. The aortic pressure was preserved better. There was an increased aortic compliance resulting in less impedance to ventricular ejection with propofol. And there was an increased, so those are all positive, okay, for propofol over isoflurane. On the flip side, patients who were maintained under anesthesia with propofol, particularly those that required higher doses of propofol to maintain anesthetic depth, whilst they still had higher mean arterial blood pressures and decreased requirement for vasopressors and so on, there was an increased requirement for the technician or veterinarian looking after the anesthetic to provide intermittent positive pressure ventilation. And some of this may have been due to the fact that there was an elaborate study looking at diaphragmatic contractility with inhalant versus injectable anesthetic agents, and they found that propofol inhibited diaphragmatic contractility to a much greater degree than did isoflurane. So, based on this collection of studies that I've listed in the bottom of this slide here, propofol has some advantages if we're administering it as a continuous infusion in patients that might be a little sensitive to the deleterious effects of inhalant anesthetics, namely decreased cardiac output and decreased systolic arterial blood pressure or mean arterial blood pressure. However, we need to be mindful of the fact that these patients might need to be ventilated. So an anesthetic rebreathing bag may need to be compressed by the nurse. That's going to tie up some staff. So obviously that's something to factor in. We know the reason for it because of potentially a greater inhibition of diaphragmatic contractility. What about alfaxolone versus a bolus versus a continuous infusion of alfaxolone? Now, just sort of changing tack there. The last slide specifically was all about propofol versus isoflurane. I want to talk now about alfaxolone and how it compares when we're giving it as an intravenous bolus versus a continuous infusion. Alfaxolone's got quite similar properties to propofol. We don't see oftentimes much change in heart rate following induction, but there are significant decreases in systolic arterial pressure after rapid induction, quite similar to propofol, but no significant drop in systolic arterial blood pressure if we inject it slowly. So those of you who are as old as me will remember when propofol first became available as an anesthetic agent in the veterinary field, we were advised to give it as a bolus, perhaps 2/3 of the dose as a bolus, very quickly over about 5 to 10 seconds, and then wait for its effect. And one of the deleterious side effects of that technique was that not only was post-induction apnea a real issue, but we also saw significant decreases in systolic arterial blood pressure with these rapid injections. And so in the last 20 or so years, we've moved to a much slower induction protocol using propofol, and they found that with alfaxolone that a slower induction protocol results in less decreases in systolic arterial blood pressure. With alfaxolone bolus, you see minimal decreases in respiratory rate with slow induction, and high doses of continuous infusions, as with propofol, are more likely to mean that your patients require intermittent positive pressure ventilation. So, in summary on this slide, alfaxolone bolus versus CRI, if you give it as a bolus, you are likely to see significant decreases in systolic arterial blood pressure. But if you administer it slowly, the side effects are reduced Likewise, with propofol, higher doses of continuous infusions might require you to administer intermittent positive pressure ventilation. So what about alfaxolone versus continuous infusion versus isoflurane? Well, there was an interesting study looking at cardiovascular function during maintenance of isoflurane versus alfaxolone in greyhounds experiencing blood loss. So they induced blood loss in these dogs and then compared them, isoflurane and alfaxolone continuous infusion, to see whether or not there was any significant difference. There was no difference in oxygen delivery or the severity of shock with isoflurane versus alfaxolone in hypovolemic dogs. The only change the study significantly found was that there was an increase in blood lactate with isoflurane that was greater than that observed with alfaxolone. Now, we could go and spend an entire hour talking about blood lactate, but essentially what this means is that when you see an acute increase in blood lactate when there's no difference in oxygen delivery, usually we begin to be concerned about physiological stress that our patient is under. And so it's more likely that the physiological stress of hypovolemia was worse in patients that had isoflurane than it was in alfaxolone patients, treated patients, which might mean that alfaxolone blunts that sympathetic nervous system response a little bit more than does isoflurane. But it's not entirely clear why that increase in blood lactate was present. Let's compare another protocol here: fentanyl in combination with diazepam and propofol continuous infusions versus an alfaxolone continuous infusion. Okay, and this study here looked at dogs that were of poor anesthetic risk. There were similar profiles of systolic arterial blood pressure and cardiac output in the alfaxolone anesthetized group compared to the fentanyl diazepam propofol combination group in these compromised patients. So the conclusion was, yes, alfaxolone has some side effects that we need to be mindful of, such as decreases in blood pressure, increased requirement for ventilation therapy, and so on. And it may, not have significant advantages in the previous study over isoflurane, at least in that study on hypovolemic greyhounds. But it seems to have a similar efficacy or similar usefulness when compared to what might be considered quite a safe protocol, one using fentanyl, diazepam, and propofol. So that's what I had to say about alfaxolone. All right. So it's not without its faults. Neither is propofol, neither is isoflurane. Let's have a look at isoflurane versus ketamine, and I've written plus or minus diazepam induction. What we find is that ketamine is associated with an increased heart rate following induction, but systolic arterial blood pressure is maintained following ketamine diazepam induction compared to isoflurane. CO2 levels were pretty similar. The PaCO2 level was similar between both groups of patients, those anesthetized with isoflurane and those anesthetized with ketamine. And this is interesting because post-induction apnea is a reasonably common, or the perception is that it's a reasonably common finding in the patient that's had diazepam ketamine induction. But if you take inductions reasonably slowly, it doesn't appear to have a much greater incidence of post-induction apnea than other injectable agents as well. But increased heart rate and systolic arterial blood pressure is maintained compared to isoflurane. So in that regard, diazepam ketamine may be a superior agent, particularly when we consider induction. What about continuous infusion? If we maintain patients on isoflurane for anesthetic maintenance or versus a ketamine continuous infusion, mean arterial pressure increased in hypotensive septic patients with ketamine, whereas isoflurane patients remained hypotensive. So in this instance, hypotensive septic patients that received a ketamine continuous infusion actually showed some increase in vascular tone and an increase in mean arterial blood pressure. This mean arterial blood pressure is not entirely just due to increase in vascular tone. Some of it will be due to the increase in heart rate that's observed with ketamine, and also the increase in cardiac contractility as well. PaCO2 was similar. Preservation of diaphragmatic contractility with ketamine continuous infusion is similar to isoflurane. Systemic vascular resistance in ketamine anesthetized patients systemic vascular resistance was increased in ketamine anesthetized patients, and it was decreased in isoflurane in septic patients. And believe it or not, lactate decreased in septic patients maintained on ketamine continuous infusion, whereas with isoflurane, it increased. So we see here that ketamine has a reasonably good safety profile, at least in terms of maintaining mean arterial blood pressure, in maintaining diaphragmatic contractility, and obviously in reducing the stress-induced potentially increase in blood lactate in septic patients as well. And a lot of anesthetic protocols that you'll see for compromised patients, fentanyl is a key component of them because it's a very, very effective analgesic agent. It's short-acting analgesic agents. You run it by continuous infusion, and therefore, by virtue of the fact that it provides a significant analgesia, has some max sparing effect, so we can decrease isoflurane concentrations. There are a couple of studies here looking at isoflurane versus fentanyl for anesthesia. And what they found was that fentanyl use can decrease the requirement for isoflurane concentrations to maintain a surgical plane of anesthesia by 35% when patients were maintained at 10 micrograms per kilo per hour, which is a fairly standard anesthetic dose. Some patients showed bradycardia, and a bradycardia in some patients might reduce the improvement in mean arterial blood pressure from a reduction in inhaled isoflurane concentration. So what the sentence is really saying is that, all right, we drop our isoflurane concentrations, we might expect mean arterial blood pressure to increase. But fentanyl will cause in some patients quite a profound bradycardia, and that will decrease cardiac output, and it can eventually lead to a decrease in mean arterial blood pressure. So we might not see that change in blood pressure if we're just using fentanyl. It does reduce diaphragmatic contractility more than isoflurane, especially at higher continuous infusion doses. And by higher, I mean at that 8 to 10 micrograms per kilo per hour dose range. So that is a time when we may need to, in some patients, look at the requirement to provide them with some ventilation assistance, some intermittent positive pressure ventilation. These patients, and it should be stressed that this would go for propofol as well as alfaxolone, they don't stop breathing at these higher continuous infusion rates. We just need to augment their respiration in order to maintain effective respiration and maintain end-tidal carbon dioxide concentrations within the normal ranges. What about lignocaine or lidocaine? Infusion of a lignocaine continuous infusion reduces isoflurane concentration requirement to maintain surgical planes of anesthesia by 16 to 18% at 2 milligrams per kilo per hour. And if we go up to 3 milligrams per kilo per hour, which is still well within the therapeutic range in dogs, we can reduce it by up to 43%. It's got a huge effect on the requirement of your patient to have isoflurane to maintain surgical plane of anesthesia. It has minimal effects on heart rate or blood pressure when used as a single agent. That's important. So if you're combining it with fentanyl or ketamine or a combination of the two, then you might see some decreases in heart rate. But as a single agent, it's not associated with decreasing heart rate or blood pressure. And it does improve analgesia in anesthetized patients. So by way of some sort of summary there, I'm just going to go back to this slide here. By way of some sort of summary, I think that we can appreciate that while I've titled this talk, Stay Away from the Gas, MAC Reduction in the Emergency and Critical Patient, it's not as simple as just giving your patient an alfaxolone continuous infusion, maybe with some fentanyl, and decreasing your isoflurane concentration, and everything's going to be fine with your patient. You might need to ventilate that patient. You might still need to use some vasopressor agents in order to maintain systolic arterial blood pressure. So I think that the title was deliberate of this talk because I didn't want to throw the baby out with the bathwater. That is the right way to say that analogy. So I think that isoflurane is a useful drug in these patients, but it does have some side effects, as do all of the other anesthetic agents that we use. Now, the tables that I have here, I've actually given you the original copy of this journal article here by Steve Haskins, the late great Steve Haskins, on comparative cardiovascular and pulmonary effects of sedative and anesthetic agents and anesthetic drug selection of the trauma patient. It's an old article now, way back in 2006, but there's lots of good data there. And this really summarizes what I think we've spoken about so far. There was no alfaxalone included in this study because it wasn't available in the US at the time that this study was conducted. But we do have ketamine and propofol and isoflurane, thiopental. I want you to look at thiopental, but pretty much ignore it for the purposes of your emergency and critical patients. And that's because thiopental, despite having quite a reasonable safety profile with regards to systolic arterial blood pressure and cardiac output and other things like that, is quite an arrhythmogenic drug. And the arrhythmias really only go away with thiopental when you pre-medicate your patient with acepromazine. Now, acepromazine is not a sedative drug that I'm almost ever going to use in an emergency and critically unwell patient that requires an anesthetic. Okay, I might use it every now and again as a sedative in a relatively healthy patient just to provide some decrease in activity level, most notably in patients with severe respiratory distress. Sometimes you might use it. But as a pre-medication for a patient that's an emergency or critically unwell patient, it's hypotensive, it's long-acting, and there's no reversal agent. So acepromazine is off my list of pre-medication drugs for an emergency patient. So therefore, even though thiopentone in these graphs that you'll see in the next few slides looks like a great anesthetic agent, it's too arrhythmogenic for me to use. And because I can't use acepromazine to negate the arrhythmogenic effects of it, I'm not going to use it at all. So that's what we'll say about thiopentone. But let's have a look at changes in the heart rate with these different anesthetic agents. Ketamine, after induction, will cause an increase in heart rate that over about 30 minutes reduces to normal. We can see that propofol and isoflurane both cause a little bit of a decrease in heart rate, but 120 in this group of patients down to around 98 to 110 is not too bad in terms of decreasing heart rate following induction with these drugs. What about cardiac output here? We can see that ketamine in the red here, we have ketamine causes an increase in cardiac output. This is due to two things. One is it's that increase in heart rate, and the second thing is that ketamine increases cardiac contractility, and that's mediated by a mild sympathomimetic stimulation. We can see that isoflurane causes a decrease in cardiac output, quite a profound decrease here. We've got a cardiac output maybe of 2.3 here, and it drops down to 1.5 down, or 1.4 down here, and it really doesn't recover all that well in the first 30 minutes when animals are maintained on it. We can see propofol, when it's given as a bolus, can decrease cardiac output quite significantly as well, and it remains reasonably low throughout this period of anesthesia. What about blood pressure? Here's where we see isoflurane and propofol. Initially, after a bolus of propofol, you will see a significant decrease in systolic arterial blood pressure. If induction is taken more slowly, you'll see a less decrease, or a smaller decrease, that's better English, a smaller decrease in blood pressure. But if it's given as a bolus, the potential that you will send a normotensive patient into a hypotensive state is reasonably high. So we need to be mindful of that. As the propofol bolus starts to wear off, we do see an increase in blood pressure. But if patients are maintained asleep on isoflurane, their blood pressure remains quite low. And that's one of the big reasons why we want to try to think about decreasing isoflurane concentrations during anesthesia in these emergency and critical patients. Carbon dioxide concentrations, the biggest increase in carbon dioxide concentrations occurs around 5 minutes after induction, and that's usually just associated with post-induction apnea in these patients. So CO2 will build up, but as patients regain the ability to breathe, there's not an awful lot of difference between these anesthetic agents. Changes in arterial oxygen concentrations. Well, these are healthy patients that are being anesthetized here. What we do see is that that decrease in systolic arterial blood pressure combined with a bit of apnea in that post-induction period can mean that propofol can cause a bit of a decrease in arterial oxygen concentration. It's quite acute. It lasts for about 5 minutes or so and then increased back up to being, within the normal range. But be mindful of that, because when you're inducing anesthesia, especially in a compromised patient, but even with healthy patients as well, if you do notice that post-induction apnea that can take place, providing some ventilation assistance for those patients while the anesthetic agent redistributes away from the brain and enables the respiratory center to resume normal control of respiration, that can reduce this change in arterial oxygen concentration that's observed. And finally, on the slide here, we have changes in tissue oxygen delivery. Now, with all of the deleterious effects of propofol and isoflurane we've seen in the last few graphs, obviously they tend to be sitting at the lower end of this particular graph. We notice that thiopentone is also reasonably low. The control animals that were not anesthetized, they had just an tissue oxygen delivery that was the same, but ketamine resulted in improved tissue oxygen delivery. And this may be one of the reasons why things like blood lactate concentrations actually begin to decrease in patients that are maintained with ketamine continuous infusions. So, having looked at all of that, when should we use inhalant anesthesia in the critically unwell patient? Well, I've written optimal use with a question mark. What I want to do in my patients is to minimize the concentration of my inhalant anesthetic agents to minimize the deleterious side effects. If I don't have hypotension in my patient, then inhalant anesthesia is probably going to be fine. But if I can minimize the concentration of inhalant so that I can prevent or reduce the impact of that decrease in cardiac output and hypotension in my patients, then that's what I'm going to use. That's what I'm going to do. That's what I wanted to say. However, if I just reduce the concentration of my isoflurane without replacing my anesthesia protocol with anything else, my patient's going to wake up, and that's undesirable. So I need to then think about using continuous infusions of some other things like opioids, like fentanyl, like ketamine and lidocaine. You could also use continuous infusions of alfaxolone or propofol, and you could even add in there some benzodiazepines as well. Now, benzodiazepines have fairly minimal effects on the cardiovascular system, minimal changes in heart rate, minimal changes in blood pressure. Their biggest disadvantage is that they're metabolized in the liver quite extensively. So if you've got a patient with liver disease, then you need to be mindful. Having said that, your opioids, ketamine, lignocaine, alfaxolone, and propofol are all metabolized in the liver. So in a liver patient, we probably want to try to keep the use of all of these to a minimum and maybe use slightly higher concentrations of inhalants, and then treat a very fine balancing act of using inhalant anesthesia to keep my patient asleep and to minimize hypotension in my patient by using low doses of ketamine and lignocaine, maybe some opioids as well in my patient too. So I think you see where we're going here. So at this point, I just want to remind you of an upcoming veterinary course that we have. Veterinary nurses, we have had to do this course before as well. They have really, really liked it, veterinary nurses and technicians. It's on anesthesia and analgesia in the emergency and critical patient. We go through in this course a bit about the pharmacology of the drugs that we're going to use, a little bit about where they're metabolized, how we adjust the doses of these drugs based on the severity of illness in patients with liver disease and the severity of illness in patients with kidney disease. We go through developing anesthetic protocols or techniques for a whole range of diseases, from neurological patients to patients with urinary tract obstruction to patients with severe abdominal disease to septic patients to patients with respiratory disease as well. And we're going to touch on a little bit of this evening as well. Course is 4 weeks long. We have a tutorial much like this every Monday night during the course for the whole 4 weeks of the course. The course is RACE approved, so if you need RACE CE credits, it is all approved for you. And the course is assessed using a short assignment, which we'll put up usually in the second or third week of the course, and we grade that assignment. It's individually marked, so you get really bespoke individual feedback. And these courses that we run here at Vet Education, they're really designed to help you utilize the information in your practice. I don't want you to go away from the course thinking, well, I got a lot of information that I can't use in my practice. So we tailor the information that we give you, the advice that we give you based on the information you give me as a tutor on what you can and can't do in your practice, the restrictions with regards to the drugs that you're allowed in your particular country, or the legislation regarding anesthesia in your country as well, and or in your state, and also the sorts of patients that you see and the equipment that you've got in your veterinary practice. So that course starts on April 18. If you need any more information, visit our website, veteducation.com.au, or shoot me through an email. Charisma will put my email address up in the chat there for you as well. So now what I want to talk about is how I approach the critically ill patient that needs to have an anesthetic. Okay, the first thing is I'm going to assess my patient. Now, sometimes the assessment might be quite rapid, because if I have a patient that has a piece of meat or a ball stuck in its pharynx and I need to anesthetize that patient in order to extract that object, I'm going to fall back on the pharmacology that I know, the skills that I know and have developed over the years to be able to safely anesthetize that patient to facilitate the removal of that foreign body or that swelling or whatever it happens to be. But we need to assess the patient. And in assessing the patient, that means a thorough physical examination, a thorough history. We need to identify potential risk factors. And for you and I and the nurses and technicians that you work with, identifying risk factors is as simple as identifying everything that's wrong with your patient. Because when we anesthetize a patient, we take an awake, usually, individual patient, and we give them a toxin in a measured dose that renders that patient unconscious. So risk factors for me are anything that is going to make that procedure more risky for my patient. It might be an electrolyte abnormality. It might be an abnormality of level of consciousness that I might need to use way less sedative or anesthetic agent than I need to before. It might be that hypoxia or hypercapnia are risk factors. There might be underlying heart diseases, abnormal cardiac rhythms. There might be an immense amount of pain that is present in my patient. The patient could have low PCV. They could have thoracic wall disease. They could have pneumonia. They could have a pneumothorax. Anything that is abnormal in your patient, you need to write these things down. And I mean write them down, physically write them down, or type them into your computer records if that's the way you've gone. But I'm an analog veterinarian. I like to write things down, and that way myself and everyone I'm working with has got a bit of something sitting in front of the patient, and we can then correct as many of those risk factors as we possibly can before I use my anesthetic agents to induce anesthesia. So let's take a patient with pancreatitis and sepsis. Okay, this patient might be hypovolemic. It might have severe systemic inflammation. So I know that there's going to be a decrease in cardiac output, and maybe the systolic arterial blood pressure is low already before I induce my patient's anesthesia. Maybe the patient's very, very painful. So I need to factor that into the stress response that my patient's going to have. I need to factor that into the medications that I'm going to give to my patient, not only pre-anesthetic and intra-anesthetic, but post-operatively or post-anesthetic as well. My patient might have serious electrolyte abnormalities, hypokalemia that may induce ventricular or an atrial tachyarrhythmia. Okay, so I need to think about these things so I can correct as many things as we possibly can. And during the anesthesia course, we go through this whole, we spend an entire week talking about identifying risk factors and how we correct them before we introduce an anesthetic. But I don't have time to run through all these things right now, but I'm hoping that I've given you a little bit of information about the sorts of things that you can identify in your patients, and then just work your hardest to try to fix as many things as possibly as possible. And yes, Jane, in the background, that is our new dog Vlad with a squeaky toy who's stealing my thunder, absolutely, but I'm pretty happy to have that happen. So once I've corrected my anesthetic risk factors to the best of my ability. And look, some patients are still going to be really systemically unwell because some risk factors we can't correct at all. I recall doing a diaphragmatic hernia surgery in a little cat that had been attacked by a dog, and this cat was in sepsis. It had a heart rate sitting up around 190, 200 beats per minute, despite being anesthetized with, fentanyl and ketamine, okay, as its anesthetic background in isoflurane. It was on an alfaxolone continuous infusion, and this little cat's blood pressure, heart rate was sitting around 190, 200. His blood pressure was up around 200 millimeters of mercury as well. And so despite the fact that we had corrected as much as we could, this cat's circulation was full of inflammatory cytokines, some of which cause vasodilatation, and some in this cat, as in this cat, were causing tremendous vasoconstriction. So we just had to work around with whatever we had in our arsenal to try to manage this anesthetic as best as we could. And the good news was that this particular cat recovered really, really well. But we need to choose our anesthetic protocol, and that's what I want to run through in the next little bit with us all together as a group. We're going to choose an anesthetic protocol, then we administer anesthetic, and then we recover the patient. So that's how I approach these anesthetics. I don't have, yes, I have a list of favorite drugs that I use all the time, and you might have favorite drugs that you use all the time that are safe in your hands, and I would encourage you to continue to use drugs that are safe in your hands. Okay, I'm not advocating that we all, as I mentioned before, throw the baby out with the bathwater. If you have an anesthetic protocol that is safe in your hands for patients with disease X, Y, or Z, then that's tremendous. But what I'm also suggesting is that if you're finding then your anesthetic that there are things that you would really like to go better, if you really don't like your nurses or technicians saying his blood pressure is really low, his blood pressure is low, I gave him a bolus of fluid, I'm trying to lighten the ISO, but he's waking up, what should I do? What should I do? Then maybe we can work on developing and utilizing the drugs that we have in our arsenal to try to reduce the chances of our patient becoming hypotensive and suffering from decreasing oxygen delivery. So let's have a look at three groups of patients tonight. These are the ones we're going to look at in the last little bit of the session. We're going to look at the neurological patient. I'm going to tell you my approach for the neuro patient. Then we'll have a look at acute airway disease, and you and I are going to solve an anesthetic conundrum in a patient with GDV. Let's talk about the neurological patient. And the neurological patient has got some problems, okay? It's got problems. This is, they have loss of normal blood pressure regulation in the brain. In normal patients, and in you or I for that matter, we are able to maintain normal cerebral perfusion pressure and normal perfusion pressure within our brain over a fairly wide range of mean arterial blood pressures and systolic arterial blood pressures, mediated by a fairly complex array of system of reflexes of vasoconstriction and vasodilatation in the arterioles and venules in our cerebrovascular circulation. Okay. If you have a traumatized brain or a brain that is diseased, that has a tumor, maybe the patient has seizures, maybe the patient has suffered heat stress, maybe the patient is bleeding into its brain, maybe it's had some other things as well, that blood pressure regulation in the brain is lost. And what this means is that that is you and I, need to, in our neurological patients, maintain systolic arterial blood pressure between 100 and 120 millimeters of mercury in order for the brain to achieve normal perfusion pressure. If it drops below that, if systolic arterial blood pressure drops to 90, our brain will not get normal cerebral perfusion pressure, and oxygen delivery to the brain falls. Neurological outcome in human patients with head trauma is 2 times worse, okay, if systolic arterial blood pressure is maintained at 90 millimeters of mercury versus 100 to 120 millimeters of mercury. It makes a huge difference. So we need to make sure that our patient's blood pressure is normal. Patients with central nervous system disease also can have shock. Okay, they may have hypotension due to blood loss if they've got trauma. They may have hypotension due to severe inflammatory disease elsewhere if they've been attacked by an animal that's bigger than them, or if they've got severe sepsis or infection. They may have had blood loss, they may have decrease in hemoglobin concentrations or decreased PCV, and so oxygen delivery to the brain may be affected as well. They can also have abnormal respiratory function. Let's take an animal like this poor little cat on the screen here that's been hit by a car. This patient may well have bruising to its lungs, so it might have pulmonary contusions. Why does that affect brain function? Well, if you can't breathe properly and get enough oxygen into circulation, then oxygen delivery to the brain decreases, and then that can have serious implications in terms of metabolic activity, stress level in the brain, oxygen consumption, and in the brain as well. And traumatized brains have a higher rate of oxygen consumption to normal brains, so any decrease in oxygen delivery to the brain caused by lung disease can mean that a minor change in oxygen delivery can have a significant impact on neurological function. Many of these patients can have abnormal neurological activity and metabolic rate as well. So this cat with a traumatized brain here, because it's got damaged neurons, will have an increase in neurological activity. Patients that are seizuring obviously have an increase in the rate of neurological activity, and so subsequently they consume more oxygen and produce more carbon dioxide. And one of the big problems with carbon dioxide is that carbon dioxide levels in the brain are a potent vasodilator. And on the surface of it, that might sound like a good thing, but if we cause profound vasodilatation in the brain, remember the brain is encased within an inelastic skull. So what happens if we get excessive vasodilatation in the brain is that intracranial pressure increases. The brain parenchyma becomes compressed and blood flow to individual neurons reduces. So we need normal carbon dioxide concentrations in circulation. There are other things as well. So hopefully you can see that both the cardiac function, shock, respiratory, due to lung injury or whatever, and neurological function are interlinked, because if our brain doesn't function properly, then we get inappropriate vascular tone and inappropriate nervous system discharge to the respiratory tract, and we can end up with hyperventilation or hypoventilation coupled with circulatory problems as well. And then don't forget that patients with neurological disease can have other diseases as well, other conditions or illness. That trauma can cause, pulmonary contusions, as we've already mentioned, and shock, but patients may have vomiting and aspiration, they may have toxicities, they may have metabolic diseases, or they may have suffered, snake bite, for example, that's caused hypoventilation as well as hemorrhage into their brain. So how do we reduce the risk in a patient with central nervous system disease? Well, we can normalize blood pressure. How do we ensure that we give enough fluid to our patient's brain so that we maintain normal blood pressure, but not too much fluid, that all the fluid starts to leak out of the blood vessels and sits in the brain interstitium and increases intracranial pressure? This is the question that doctors and veterinarians have pondered for many, many years. And our current thinking is that we need to treat shock in patients that have central nervous system disease. If they are in shock, then we need to treat them for shock with shock rates of fluids. So I've written high volume, then low volume. What I mean by that is I'm going to treat my patient, if it's a dog, with 10 mils per kilo of lactated ringer solution given in 10 minutes. And I'm going to repeat those boluses until I don't see any further signs of improvement in cardiovascular function. So my heart rate, I want to see continuing to fall to within the normal range. I want blood pressure to increase to that 100 to 120 millimeters of mercury level. And I want other perfusion parameters like lactate, for example, and also mucous membrane characteristics and blood pressure to remain normal. If I find that my patient is not improving with any subsequent bolus, I need to find out why that's the case. And that is a subject of an entirely different lecture called The Patient That Doesn't Respond. And if you're keen on having a repeat of that, I did this lecture a couple of years ago as a free lecture, then I'd really be keen to do that. So type in a yes or no if you're interested in that in the chat box there. So once we have treated our patient for shock, then we decrease the rate of intravenous fluids down to maintenance rates. So maintenance rates of fluids. So I'm not going to have my patients on twice maintenance or 3 times maintenance rates of fluid. I treat them for shock and I decrease the fluid rate to maintenance. Oh, I mentioned dogs, 10 mils per kilo in 10 minutes, repeating that until I didn't see any more improvement. For cats, the rate's going to be 5 to 7 mils per kilo over 10 minutes because they've got a smaller blood volume and I don't want to overload cats. Then decrease the rate to maintenance rates. How else can I reduce risk to my patient? I mentioned, lung disease is a problem, respiratory tract disease is a problem. So oxygen supplementation, maybe even intubating my patient and providing them with some ventilation support once you get anesthetic induction is super important. What I want to do with this is get as much oxygen into my patient's lungs as possible so that that is not a factor in my patient's neurological outcome. I want my patient's oxygen delivery to be as good as it can be. But the other thing is I don't want too much carbon dioxide in my brain, because if I do, I get cerebrovascular vasodilatation, my patient's brain swells, and we get a decreased oxygen delivery to our brain. So I need to make sure my end tidal carbon dioxide concentration is normal, be around about 33 to 42 millimeters of mercury. Some people say 35 to 45, that's perfectly okay. Millimeters of mercury for end tidal CO2. If you don't have end tidal CO2 monitoring in your practice, then what I would recommend is if you have a neurological patient that you anesthetize, that you start intermittent positive pressure ventilation at around 10 mils per kilo, about every 3 or 4 seconds for that patient's an entire anesthetic, so augment its own respiratory efforts so that you can minimize the risk of getting excessive buildup of carbon dioxide. If the patient needs red blood cells, will transfuse it. If it needs ventilation assistance, we've already said give it early. And control blood glucose. Interestingly, high blood glucose concentrations in patients with central nervous system disease are associated with worse neurological outcome. This specifically applies in particular to patients with head trauma, but patients with prolonged hyperglycemia from seizures and other disease as well tend to do a little bit worse. So we might, in some patients, even start our patients on an insulin continuous infusion to try to decrease those glucose concentrations to within the normal range. Likewise, if your patient is hypoglycemic, we need to supplement our patients with glucose so that our neurons have got something to use for energy. Can I please repeat the IPP if you don't have end tidal CO2 monitoring ability? Absolutely. So I generally breathe at about 10 mils per kilo, and that's at about one breath every 3 to 4 seconds or so. You might not need to breathe that fast, but in patients, that's about if you're breathing every 4 seconds, that's 15 breaths a minute. It's a physiological respiratory rate. 10 mils per kilo is not going to overinflate your patient's lungs. It is not going to cause, over a short anesthetic, it's not going to cause, and by short, I mean less than sort of 2 or 3 hours, it's unlikely to cause any pressure-related damage to your patient's lungs. Now, how do we calculate the 10 mils per kilo if we're using an anesthetic rebreathing bag? It's a bit of an approximation, to be honest. So if I've got a 5 kilo cat and I need to breathe 10 mils per kilo, there's going to be 50 mils that I need to breathe for my cat. If I have a 250 mil anesthetic rebreathing bag on my patient's circuit, that means that I need to squeeze that fully inflated bag about 20%. So this takes a little bit of communication between ourselves and the nurses or technicians we're working with so that we don't accidentally squeeze the entire contents of the rebreathing bag of 250 mils into our 5 kilo cat each time it receives a breath. So we just do a rough calculation. 10 mils per kilo is a fairly safe volume, and then we do squeeze that based on an approximation of the size of the bag and how much we need to squeeze it. If you've got pressure monitor on your anesthetic circuit, how quickly can you squeeze that breath in? Usually over a couple of seconds. I like to take sort of at least a couple of seconds to breathe in for the patient. And if you've got a pressure monitor, you don't want your pressure gauge to rise above 20 centimeters of water. 20 centimeters of water is about where I'd want it to be. 15 to 20 centimeters of water is a pressure that's normal airway pressure in the dog and the cat. If you're getting up to 25, 30 millimeters of 30 centimeters of water, you're probably squeezing that rebreathing bag a little too hard, and you can cause some pressure-related damage to the lungs. So now we've talked a little bit about risk reduction in terms of looking after our patient's problems. Now we have to choose something to anesthetize our patient with. So what am I going to do? I'm going to avoid drugs that cause hypotension. So acepromazine, it's out. Okay, it's non-reversible, it's long-acting, it's going to cause hypotension. So I'm not going to use acepromazine in a patient with CNS disease. Inhalant anesthetics, okay, they do cause hypotension. We know that from the clinical studies. So if I'm going to use an inhalant anesthetic, like isoflurane, for example, I'm going to use a lowest dose possible. If I have to use it, I'm going to use the lowest dose possible, which means I've got to use some other things. I'm certainly not going to induce anesthesia with an inhalant anesthetic drug almost ever. I think there's many safer options out there. Even some intramuscular options are safer than using an inhaled anesthetic induction. So I stay away from anesthetic induction using inhalants. I'm going to use with some caution some drugs that increase intracranial pressure. So a bolus of ketamine, yes, it does increase intracranial pressure. However, a continuous infusion is okay. In fact, I'm writing a blog right now on ketamine because there's lots of stuff about ketamine that we didn't know about that we know now, and ketamine's actually quite good. And ketamine is a continuous infusion. We saw from some of those previous slides improves cardiac output and tissue oxygen delivery. So I like the idea that ketamine might improve these things as a continuous infusion. It's also anti-inflammatory, so it will reduce inflammation in the brain. And in fact, in humans that are maintained on a continuous infusion of ketamine, yes, they get some pretty funky dreams, I'm given to understand, but neurological outcome is improved in patients that are maintained on continuous infusion of ketamine immediately post head trauma. So we'll keep the CRI as an option for us, but I'm probably not going to use a ketamine bolus in my patient with head trauma. I'm going to avoid drugs that reduce oxygen delivery. Now, we didn't speak much about the alpha-2 agonists like dexmedetomidine and medetomidine. They're very, very effective analgesic agents, very effective anesthetic adjuncts, but they do reduce oxygen delivery, particularly in that initial phase where we get a really intense peripheral vasoconstriction and a subsequent decrease in heart rate. We get a massive decrease in heart rate there, and that can lead to a significant decrease in oxygen delivery. So I'm probably not going to use an alpha-2 for these patients. And drugs that cause significant hypoventilation. Well, this is a lot of things like our alpha-2 agonists. Morphine and methadone given as boluses can cause quite profound decreases in respiratory rate. Certainly you can get that with fentanyl as well, but it seems to be a little less pronounced than it is with morphine and methadone. So I normally avoid those drugs in a head trauma patient anesthetic. So what have I got left? I've got fentanyl left. I've got butorphanol, I've got midazolam. It's not an analgesic, but it will reduce anxiety a little bit and reduce the seizure risk. I've got ketamine, propofol, and alfaxolone continuous infusions, and I want to keep my isoflurane concentration well below its MAC of 1.2. And when I anesthetize my patient, I'm going to ventilate them. So what I do is I give my patient, if my patient's not too painful, I might use butorphanol with maybe midazolam, ketamine, or maybe with butorphanol or fentanyl, maybe with a propofol or alfaxolone induction, and then I might maintain my patient on a ketamine fentanyl continuous infusion with low doses of isoflurane, or I could maintain my patient on a fentanyl propofol or a fentanyl alfaxolone continuous infusion. I've got some options here that mean that I can reduce the amount of isoflurane that I use in my patient to maintain normal blood pressure, because it's so critical in these neuro patients. So an example protocol: pre-oxygenate your patients for at least 10 minutes in the oxygen case to increase the amount of oxygen dissolved in your blood. Then fentanyl plus or minus midazolam, or maybe even a ketamine CRI before my patient is even anesthetized. I'm going to induce with an anesthetic agent that doesn't increase blood pressure in my patient's brain as like ketamine bolus will. So I might use propofol or alfaxolone, and I can maintain my patient on fentanyl, ketamine, lidocaine, or alfaxolone or propofol, plus or minus isoflurane as well. Good question here. How much pain relief does butorphanol provide? Not much. Okay, it's good for mild analgesia provision only. So if your patient has got more than a minor injury, I probably would not use butorphanol as an anesthetic protocol. This cat that's on the screen here, I'm not going to use butorphanol for that. It's probably not good enough for my patient's analgesia requirements. Granted, I could use butorphanol and add in lignocaine, and I could add in some ketamine as well, but probably, because the bulk of our analgesia is going to be provided by our opioid, I probably want to start off with an opioid with good analgesic properties. Great question. Let's talk now about the respiratory patient, because I know I've gone a little bit over time already, and I apologize for that. Let's have a look at a couple of videos. I want you to think about what you would consider an anesthetic agent for this. And let's have a look at this doggy. He was a healer. He was just walking in. Walked into the clinic, and he was tied to the bench there, and I just happened to notice him and thought, oh, I don't like the way he's breathing. Have a look at what you can see. Well, you can see he has a Kong ball in there. Now, the good thing about this ball is that it had a hole in it, and the hole was oriented cranial to caudal. So this dog didn't have a complete airway obstruction, but he had a tiny, tiny little hole that he could breathe through. So what kind of an anesthetic agent do we want to use, or what sort of problems do we see with this particular dog? I see potential for hypoxia. I see potential, maybe not for hypercapnia, but when I anesthetize this patient, if this relative hypoxia has been going on for, half an hour or so, the owner's brought him into us in the car and he's been breathing like this. If I anesthetize this dog and I'm not careful, he could die, drop dead off the end of the needle if I'm not careful with the dose. So whatever anesthetic drug I'm going to use for him, I'm going to use a really low dose to start with. I want to see what his physiological response is going to be. Let's have a little look here at what we did. I think you're breathing better. No, I didn't put that in. What we did anesthetize this dog with, I gave him some pre-oxygenation with a transtracheal oxygen catheter, and then I used a little bit of butorphanol. This is where butorphanol comes in nicely, because it sedated him a little bit, and then I gave him the tiniest dose of alfaxolone. And alfaxolone gives a nice, smooth, rapid induction, but I gave him a small amount, and he was still relatively awake. So you titrate that anesthetic up. If I give him a big dose, I can't suck it out of him. So if I give him a big dose and he has an adverse reaction due to the acidosis and a hypoxia that he has going on in his system, then I'm doing CPR. So let's have a look at this little dog here. This was a little beagle who was hit by a car, and he's not looking very happy. He had a pneumothorax, so I needed to put a chest drain in this dog. You can see he's got marks on his head as well, but have a look at his breathing and think about the problems that this dog has. So he's sedated. I'll tell you already, he was sedated. He was on a fentanyl continuous infusion. That's why he looks a bit dopey. But he has a pneumothorax. He's not doing very well at all. He had a huge pneumothorax. I'd done thoracocentesis 3 times in this dog and got over 1 liter of air every time I did it, about every 20 minutes or so. He had a big defect in his airway that was causing this pneumothorax. But I needed to put a chest drain in. To do that, I need to anesthetize this dog because it's a painful procedure. Yes, I could put in a Seldinger catheter and in a heavily sedated patient, but either way, we're going to need to use something to sedate this patient. All right, let's get back to our plan. That's him there. Oh, whoops. So the problems are that these patients have got reduced lung reserve or reduced respiratory reserve. They've got inadequate inflation of the lungs, which can cause hypoxia. In patients that are not breathing fast enough, we can get hypercapnia. We can get metabolic acidosis as a result of that. Coupled with that, patients with respiratory disease might have trauma as a concurrent disease. They might have fractured limbs, bleeding, and so on. They may have heart disease. They may have infection or inflammation, neoplasia, if they've got aspiration pneumonia, for example. So these are the problems that we've identified. So giving a patient oxygen, getting some sort of method by which you can give your patient oxygen pre-anesthetic is really important. Managing hypercapnia is something you need to attend to straight away. As soon as you get an ET tube in your patient, you need to start breathing for these patients, as we talked about for patients with central nervous system disease. Then you need to make sure your patient's got an adequate packed cell volume. That's usually in a trauma patient, anything sort of above 27 to 30%. You need to make sure that any underlying disease is managed, okay, or at least begun to be managed. Treat patients for shock, treat them for infection. Make sure that, many times in bite wound patients, for example, you need to anesthetize them to clean out wounds. And so sometimes infection control or an inflammatory focus control occurs concurrently with your anesthesia. But we need to make sure that, things like electrolyte imbalances and so on are all tended to as well. Just before I move on, there's been a great question. Would I set up 3 continuous infusions, for example, of fentanyl, ketamine, and alfaxan propofol? Yes. In fact, the way I set them up, I normally have them in separate syringes and separate syringe drivers, or you can use them in 3 separate IV fluid bags. You could combine potentially the fentanyl and ketamine in one bag. The reason I like them separate is so that I can change the rate of one drug without affecting the rate of the other drugs. Certainly, if you're using alfaxalone as a partial intravenous anesthetic maintenance agent, you'll need to keep that separate from your other drugs. Likewise with propofol, but I like to have fentanyl as a separate analgesic CRI. Sometimes I'll combine the ketamine and the lignocaine if I'm using ketamine and lignocaine together as part of an analgesia protocol, anesthesia protocol in my patients. But if you've got the equipment and you can keep them separate, then that's great. If you need to combine them, I would probably keep the opioids separate and have combined the ketamine and the lignocaine, or you can keep the ketamine separate, combine the opioid and the lignocaine, whichever you prefer as your technique there. But as I say, separate is great if you've got the gear for it. All right, risk reduction, oxygen, ventilation support. Avoid depressant analgesic drugs. When I say depressant analgesic drugs, I mean respiratory depressant analgesic drugs like methadone or alpha-2 agonists. I've written morphine plus or minus there because morphine actually increases the depth of respiration, even though the rate decreases. The problem with morphine is that some patients will vomit in that acute phase after receiving it. and they can pant quite a bit. They will with methadone, and some of them can with fentanyl as well. So that's one of the disadvantages of opioids. We can use fentanyl, we can use butorphanol, which really only, as I mentioned before, only provides mild analgesia. So it depends on what else is going on with your patient. What else could we use? We could use alfaxalone, we can use diazepam ketamine, we can use propofol if I need rapid airway access. So if my patient if I need to get control of their airway reasonably quickly or intubate them quite quickly, then I'll probably err to using alfaxalone or propofol as the induction agent, because they give a smoother, more rapid induction than does diazepam ketamine. But I will stress that in patients with airway obstruction, what I'm generally doing is placing what's called a transtracheal oxygen catheter, which is like an angiocath, about a 14 to 16 gauge angiocath. It's an over-the-needle catheter. I'll place that between the tracheal rings and the cervical trachea and pass that down as far as the thoracic inlet, and then attach your oxygen hose to that. And that will help enable you to pre-oxygenate a patient with airway obstruction. You can if your patient is able to exhale okay, but they're having real trouble breathing in, you can connect your oxygen hose, completely cover the end of your transtracheal oxygen catheter, because the oxygen will go into your patient. If they're breathing out around the outside of the obstruction that they have in their airway, they'll usually be able to get rid of carbon dioxide and any excess oxygen you're giving them. If the animal has a complete sealed obstruction, and I've only seen a couple of these, one was with a rubber ball, the other was with a stake that a little puppy had got into, and this meat was wedged in the back of its throat. You need to enable some means for carbon dioxide to get out of that patient. So you could put in a second transtracheal oxygen catheter if you wanted to enable carbon dioxide to get out of that patient while you anesthetize them. But those patients need to be acted on very, very quickly. So what have I got? Pre-medication, fentanyl or morphine or butorphanol, I think is fine for these patients. Induction with alfaxalone or diazepam ketamine or propofol, they're all good, probably going to be okay. And maintenance, isoflurane is quite okay for these patients, but I'll oftentimes have them on, depending on their underlying disease, maybe fentanyl, maybe with a benzodiazepine like midazolam plus or minus lidocaine, so I can reduce the hypotensive effects of isoflurane if my patient is hypotensive, or I can maintain them with propofol or alfaxalone. Now, I've got a video here that I'm going to show you just before we do our GDV, and it's about putting intercostal nerve blocks in a puppy. Sometimes it's not entirely related to this presentation, but I think it's important for us to think outside the square a little bit, because it's very tempting if we have a patient who's screaming in pain, that's got rib fractures, to say, oh, what other analgesic can I give it to help its breathing? Don't forget local anesthesia for some of your patients, okay, that are perhaps having some issues. So this little puppy,
this video shows the
I've narrated this, so I'll be quiet while the video takes over.
Fractured ribs. This particular patient here, we can see some evidence of fractured ribs dorsally on the left-hand side, and a partial or apparent partial collapse of the left lung on this patient, and some consolidation of that lung associated with that. On the ventrodorsal view, we can see that we have evidence of fractured ribs quite close to the dorsal segment of the rib, right from rib 5 through to 11 in this particular patient. We're obviously concerned about other trauma like pneumothorax and hemothorax. So what we see on this ultrasound here is evidence of the glide sign, which is a sign of an intact pleural space or air-pleura interface with the lung. We do, however, see on this left-hand side evidence of ultrasound lung rockets. Those vertical white streaks that we can see coming down from the white line at the top of the video there, and this indicates fluid in the pulmonary parenchyma. We don't know what that fluid is, but in the patient following trauma, we assume this to be the presence of blood or intrapulmonary hemorrhage. So this patient's being clipped and prepped, and what we're doing is just putting 0.1 of a mil of bupivacaine just caudal to each rib. A couple of rib spaces cranial to the first rib fracture and one rib space caudal to the rib fracture, and in each intercostal space associated with the rib fracture. You just go just caudal to the rib. You want to draw back on the syringe just to make sure that you're not in either the intercostal artery or vein, and then just inject the local anesthetic in that intercostal space. The reason we're using bupivacaine in this patient is that we'll get a good probably 7.5 to 8 hours worth of analgesia from this. This particular patient responded extremely well following these injections and was standing on its hind legs with its front legs on the cage bars, yelping for attention, and seemed very, very good and happy in terms of being pain-free over these fractured ribs. Prior to these injections, this particular patient was near moribund, not wanting to move around too much at all.
All right, so we're going to talk now about the GDV patient. It's time for you to hit your keyboard. Now, tell me, in the GDV patient, we've got several problems with respiratory function due to the pressure of the stomach against the diaphragm. We've got cardiovascular instability with patients that are in shock. There may be hemorrhage from a torsed or torn spleen or splenic vessels. There's third space fluid loss into the stomach and potentially into the abdominal cavities. Many of these patients will develop DIC or coagulopathies, and they're very painful oftentimes. So how would you manage this anesthetic in terms of risk reduction? Just type in the chat box anything you would like to do for a GDV patient that is coming into your practice, maybe right now in half an hour or so. What are the things that you want to manage to reduce risk when you're thinking about anesthesia in this patient? And while I'm waiting for you to type this in, Andy has written the most awesome limerick here. Anesthetics are not such a breeze, and patients with underlying disease avoid ACP. It drops their BP. Alfaxan or ketamine, yes please. I love that. So that's awesome. Thanks, Andy. Fluid therapy is one of those things. Absolutely decompress the stomach with a catheter. I love this. It's going to reduce the pressure on the diaphragm. We need to work on perfusions. Lignocaine, I love it because these patients are oftentimes going to develop arrhythmias. We know it's an effective analgesic. Pre-oxygenation, manage our blood pressure. How do we manage the blood pressure? With our fluid therapy and wise anesthetic choices. IV fentanyl, absolutely. I love this. So many good things. Pain relief, oxygenation fluids. And we're going to monitor things like PCV total protein, coagulation profiles. We may need transfusions with plasma if necessary as well. We need to maybe consider even some vasoactive agents in patients that are hypotensive on admission. So maybe even noradrenaline, perhaps even dopamine in selected patients as well. Oxygen therapy, we've got, what else have we got here? Lignocaine, alfaxan induction, fentanyl CRI, intra-op. Clancy's given us an absolute brilliant protocol here. Okay, so anesthetic drug selection, how are we going to manage it? Drugs you want to stay away from, really, really depressive drugs. I generally stay away from alpha-2 agonists. Not that they're bad drugs, it's just that some people do use them in these patients. I'm just not that comfortable with them personally, but you may work with vets, or you may be a vet who uses the alpha-2 agonists in these patients for their superb analgesic properties and their ability to reduce the MAC of isoflurane. But in terms of anesthetic drug selection, I think that things like fentanyl is great. Ketamine continuous infusion is really good. Lignocaine continuous infusion. So that's a fantastic choice of pre-anesthetic drugs. Just a note, if you're going to run a continuous infusion of an analgesic drug, you need to bolus the patient as you start the continuous infusion to get the serum concentrations up to in the therapeutic range earlier. Okay, because what will happen is, and I'm just going to see if I can draw a graph here. I'm not a very, oh, look, I've got straight lines here. Now I'm going to draw a graph. I'm going to take this away. If I just start my patient on its fentanyl CRI, over time the concentration will rise and it will reach a steady state. Okay, and this time here, I don't really know what time that is going to be, this time across here. Okay, from the beginning of my CRI to the time it reaches a steady state. It might be half an hour, it might be an hour. That's probably not what I want for my patient. So what I need to do is give my patient a little bolus here of an anesthetic drug and then put them on their CRI straight away so that I get this concentration of analgesic drug in my patient's circulation at a therapeutic level early on. And what dose do we give? Well, it's just the same dose as your hourly dose of the drug. So if my ketamine dose is 1 milligram per kilo per hour as a continuous infusion, I just give 1 milligram per kilo bolus of ketamine IV and then start my patient on a continuous infusion. Same with fentanyl. If my fentanyl dose is going to be, say, 7 or 8 micrograms per kilo per hour, I just give it a 7 or 8 microgram per kilo fentanyl bolus. And yes, do we need to bolus all of the anesthetic drugs, the analgesic drugs? Yes, you do. If you're using the drugs like propofol and alfaxolone as continuous infusion, yes, you do as well, because otherwise your anesthesia induction will be very, very slow and you won't reach steady state concentrations. Siobhan, a great comment there. She's had really critical patients that have been maintained on with a pre-med of fentanyl lignocaine, and they just have a tiny sniff of propofol, and that's all they've needed to maintain their anesthesia. So almost no isoflurane or no isoflurane at all, which is really nice for your blood pressure. And as you know, if you're a nurse or a technician, I guarantee that if you don't have to worry about a hypotensive patient under anesthesia, then you'll be happier. And by default, your vets will be happier because you're not raising an alarm all the time. So anesthetic drug selection, yes, fentanyl, ketamine, lignocaine. What do you induce with? You could use propofol slowly, or you could use alfaxolone slowly, or you could use diazepam ketamine slowly. What do I use? I use diazepam ketamine because in my hands, it's the safest anesthetic drug that I use, drug combination that I use, but in your hands, it might be alfaxolone. It might not be, it may be propofol. So yes, you can use those. And then I will have my patients on their fentanyl, ketamine, lidocaine continuous infusion. And I can give you some dose rates later on, but I'll have them on that infusion. Isoflurane concentrations may be sitting around 0.7 or 0.8%, not at 1.5 or 2%, but 0.7 or 0.8%. And systolic arterial blood pressure is maintained really, really nicely. It's sitting at around anywhere between 100 and 130, 135 millimeters of mercury. So for most of these. Now, the dose rates that we use for my surgical rates of analgesia for ketamine, it's 1 milligram per kilo. For fentanyl, it's between 7 and 10 micrograms per kilo per hour. And for lignocaine, it's between 1 and 2 milligrams per kilo per hour. What is my dose rate for diazepam ketamine? Typically, I tend to just titrate it to the patient. I'm generally drawing up about 0.5 milligram per kilo of diazepam, and for ketamine, about 5 milligrams per kilo of ketamine. How much I actually give is quite a lot lower than that. Because normally that's what I'll draw up in the syringe, but because my patient's on fentanyl and ketamine and lignocaine, I'm oftentimes giving about 1/5 or 1/4 of that dose to induce anesthesia to facilitate intubation. And then I keep the rest of that intravenous solution in case my patient gets a bit light. Then I give intravenous doses of anesthetic drug rather than turning up the concentration of isoflurane, because if I give intravenous doses of drugs that are not hypotensive, then I don't create a problem of hypotension when my patient starts to maybe get a bit light under anesthesia. Whereas if your patient gets light under anesthesia and you turn up the isoflurane concentration, guaranteed your blood pressure is going to fall. Your patient's heart rate might start to go up and tissue perfusion starts to decrease. Is midazolam the same as diazepam? No, it's not. So diazepam is more lipid soluble. Midazolam is more a water soluble drug. They are different drugs. They're used at similar dose rates, but I recommend that just consulting a pharmacology reference there for the individual differences. But you can use ketamine midazolam as an induction agent as well, or instead of rather ketamine diazepam. So an example protocol, we've already just walked through. This is my protocol here that I use: fentanyl, ketamine, lidocaine as pre-meds, and they're all given at the surgical continuous infusion rates, which incidentally are double what the analgesic dose rates are when I've finished the surgery. So fentanyl goes from 8 micrograms per kilo per hour down to 4 micrograms per kilo per hour in the post-operative period. Ketamine goes from 1 milligram per kilo per hour down to 0.5 milligram per kilo per hour in the post-op period, and lidocaine goes from maybe 1.8 or 2 milligrams per kilo per hour down to 1 milligram per kilo per hour post-operatively. Induction, diazepam and ketamine, and maintenance, they're on the fentanyl, ketamine, lignocaine continuous infusion with just enough isoflurane to keep them topped up. You could use propofol as your induction agent and run them on fentanyl, ketamine, lignocaine, and propofol continuous infusion if you wanted to, with no isoflurane at all if you wanted to. So we've reached the end. Thank you so much for sticking with us. Just remember to identify your patient's problems and then fix as many of them as possible. If you write your patient problems down, it's really hard to mistakenly forget one of them. Okay, if they're all written down in front of you, you can develop an action plan to remedy or fix as many as you possibly can, because the more normal you can make your patient before they have their anesthetic, the lower the risk is to your anesthetic. Okay, so I cannot stress that enough, that if you try and fix up as many things as you possibly can before you anesthetize your patient. The next thing, you look at your anesthetic drug cabinet and just remove drugs that have got unacceptable side effects from your protocol. Just say, well, I don't want this, I don't want that. Just remove them from your protocol and you'll be left with a bunch of drugs that are remaining. And then just devise a protocol with the remaining drugs that both you are familiar with and that your staff are familiar with and that you feel comfortable with giving your patient. Then when you administer your drugs, take care. First rule is take it really slow, okay? Unless you've got a patient who requires immediate anesthesia for airway access, okay? Take it really, really slow. I will take, just to go back to the GDV, I'll take 3 to 5 minutes sometimes to maybe 2 or 3 minutes or so before I intubate the patient, because I'm after I start inducing anesthesia, because I give a little bit of drug and then just see what it does, see what my patient does with that drug. They might go to sleep after I've given them 10% of their required dose of anesthetic, in which case I intubate that patient, they get no more induction drug and they go on to a maintenance protocol. Other patients might take a little bit more, but my rule of thumb is in an emergency or critically unwell patient, I would prefer to administer, and the protocol that I use in my head is I administer 5% of my calculated induction dose as my first induction dose for my patient. So if my induction dose is, say, 3 mils of a particular anesthetic, I will use 5% of that. So I'm giving 0.15 of a mil of this drug to my patient. All right, that's how much I'm giving, and I see what effect it has on the patient. The patient might be sitting wide awake, and 30 seconds later it might still be wide awake, so I might give it a little bit more. What I'm not going to do is give 1/3 of my anesthetic drug dose or 1/4 of my calculated anesthetic drug dose to a compromised patient, because some of them will die if you do that. If you see have a crash cart on hand and have as many staff members when you're on hand as are permitted in the situation that you're in, because the more hands you have to help out if things go wrong with your anesthetic induction, the better it is for you. Intervene early. If the patient's not breathing, breathe for them. If the patient's hypotensive, then give them fluids, give them vasopressors, monitor as much as you can in your setting, and don't ignore abnormal findings. Okay, if something's abnormal, chase that abnormal finding. It could be the patient's got a pneumothorax, they've had a bleed, they're hypothermic. Chase whatever as abnormal in your patient. And that is what I had for you this evening. Thank you so much for coming along tonight and for your brilliant questions and contribution. I'm really happy to take some more questions, but I just want to remind you again of the course that we have coming up starting April 18, where we're going to dive into everything we've talked about tonight in a lot more detail. And I see that Vlad, our little puppy dog, has joined in just for the finale to squeak his little toy. So thank you, Vlad, for that. And I'm happy to take any questions. What would be the best follow-up analgesia for a traumatic pneumothorax next day, no rib fractures, mild lung contusions? Oh, I like that question because, look, I think pulmonary contusions are oftentimes, well, they seldom occur just on their own. All right, so there's usually some degree of myocardial contusions. There's bruising to the muscle tissue, and that can be quite painful. So, you know, myocardial contusions frequently cause arrhythmias in these patients. So I'm a fan of lidocaine or lignocaine continuous infusion in combination with maybe fentanyl continuous infusion and maybe ketamine if you're really worried about some more pain. But something with lidocaine in it would be really helpful, and an opioid, generally speaking, because these things are quite painful. You could potentially use, you know, something like methadone every 4 hours or so, and then give a lignocaine as a continuous infusion. I'm not a huge fan of bolus analgesia in post-trauma patients because I think some of them feel pain before we get to them with their next dose of analgesic drugs. So I much prefer a continuous infusion of something, which is why I tend to go for methadone. But if cost is a factor, you could use morphine continuous infusion with lignocaine. It'll work really, really well. Awesome. Just looking for any other questions. Keep your questions coming if you have, and I love your feedback. Thank you so much. You guys are incredibly kind. I've loved spending the evening with you, and sorry I've gone a little bit over, well, a little bit, half an hour over time. I hope you have a lovely, safe remainder of your week, and if any of you have any questions about the Anaesthesia Analgesia course, please just reach out and let us know. Thank you again, and good evening.